Well, good afternoon, everybody, and welcome to this Baker Institute Behind the Discoveries, Changing the Future of Healthcare. My name is Matthew Keenan. Once again, I get the privilege of being able to host this webinar. And today I'm joined by Associate Professor Melinda Carrington. Melinda, good afternoon. Your job title, it is a long one. You're the head of the Baker Institute's Preclinical Disease and Prevention Lab. What does that entail?
We are the community face. Firstly, hello everybody and good afternoon. Thank you for joining. We are seen to be the community arm and the public face of the Baker Institute. So our work largely entails clinical trials and community research, going out into the community, finding and identifying people who may be at risk for cardiovascular disease. And then we are largely known for designing interventions and models of care that involve nurses to help coach people and manage people's disease.
That intervention element is something we're going to touch on today. I'd like to also do the traditional acknowledgement to country. In the spirit of reconciliation, we acknowledge our traditional owners and we acknowledge their deep connections to culture and community. We pay our respects to elders past and present, and we extend that respect to all Aboriginal and Torres Strait Islanders people today. And often when we hear those statements, sometimes when I'm at functions, I think, is that just words and going through the process? And with the Baker, it's not just words. Just in March this year, the Baker Institute received conditional endorsement for their innovative reconciliation action plan. This represents a huge body of work by the Baker Institute in conjunction with the Baker's Indigenous colleagues and stakeholders. In fact, since 2006, a reconciliation plan has enabled organisations to sustainably and strategically take meaningful action to advance reconciliation based around the core pillars of relationships, respect and opportunities. And these plans provide tangible benefits for Aboriginal and Torres Strait Islander peoples to increase economic equity and support First Nations peoples' self-determination. What was fascinating to me was to see that there was a study that showed there is 1,100 organisations in Australia who have a reconciliation action plan. Of that, approximately 250 of them are not-for-profits, which the Baker is one of those. So there's plenty of room for improvement because there's some 58,000 not-for-profits in the country. So there's some work to do, but I'm pleased to say as an ambassador for the Baker is very much at the forefront. For those of you who've got no idea who I am, I get paid to talk to a television screen, but predominantly talk about cycling. As for why I'm an ambassador for the Baker Institute, it's pure self-interest. My grandfather and two uncles on my mother's side all passed away of heart attacks in their mid-40s. And the guy who helped me get into commentating and commentate on the Tour de France was a guy by the name of Paul Sherwin. He rode the Tour de France 7 times. He was fit and healthy in his late 50s, almost 60 years of age. And a couple of years ago, he also passed away of a heart attack. And I've had a few other friends through cycling or fathers of guys that I rode with who have had heart attacks. And one of them in particular, fortunately, has survived. And as a result of that, he's become a donor to the Baker Institute. So one of the big elements coming out of that is looking at personalised care. And that's something that the Baker is working on. They're doing a lot of work to help people that are in a genetic situation, perhaps like myself, with personalised care. Here's a little video from the Baker about exactly that campaign, Campaign U. Well, Melinda, there were some staggering stats within that graphic that we just saw pop up. For everybody who is with us in the webinar, your microphones are muted, but the webinar is being recorded. We saw a question pop up about that a few moments ago, so this will be shared. We've also had a comment in the chat box from Rosemary. Thank you. The volume a little bit low, according to Rosemary. We'll try and adjust that for you so you can hear us nice and clear. And if you do want to submit a question, you can pop into the chat box and we will try and get to them. Just going through that, Melinda, looking at the stats there, one of the things that was absolutely fascinating was that there's very little care until there's symptoms arise, but one of the objectives is to getting intervention and care in there beforehand.
Yep, exactly right. And prevention, we like that. It's always better than cure. But a lot of the work that we do, and particularly my team, is trying to identify the people first before they have an event and get them on the right track and implement those models of care. Try to do it firstly with diet and lifestyle. It doesn't always mean going to reach for a pill packet, but if needed, that might be what is necessary to prevent having a heart attack or a stroke, which could be fatal.
Is that how you would describe personalised medicine in those terms, or is there more to it than that?
Personalised medicine brings in lots of information, brings in genetic information, environmental information, and lifestyle factors to try and prevent and treat and manage a disease. So it's a little personalised, more individualised to try and target what might work, and then also identify drug treatments and therapies that might work for certain groups of individuals and might not work for other groups of individuals. So it's what works for who and what doesn't work for who as well. So that's what personalised medicine is all about.
Yeah, and that it makes sense, because there's other things in our life that what might suit you as a method of learning, for example, is a different method of learning that could suit me or suit anybody else that's in this webinar. So it makes perfect sense.
And we're all different. We've all got different genes, and we've all learnt different things from how we've been brought up as well. So
yeah,
what we learn from our parents or grandparents, even how we cook our food.
So true, isn't it?
Learned, yeah. And there are triggers within us that can switch those things on and switch them off.
Yeah, I had a good question come in from Dylan already, so I'm going to jump to a few of the questions that we've had submitted already. And he wants to know what excites you most about the project that you're currently working on.
By far the biggest project that I think the Institute's seen for a long time in its history would be the EdCAD project, which is the early detection of coronary artery disease. And we're doing that via a genetic approach. Mm-hmm. So quite novel. There are traditional ways. So this project is about identifying and detecting risk before it happens. So this is this is in the primary prevention space, and this is trying to prevent people from getting the disease by looking to see whether they are in a risk category that would warrant some further investigation. And if so, if we find that there is, what we're looking for is some calcium buildup in the arteries, getting them onto the right treatments to prevent that. So I love the prevention aspect of it. And I love that we're trying to look at some novel ways over and above your traditional blood pressure and your cholesterol and age and other key risk factors that are important. We're looking to see whether genetics play a role also.
And what's the hope in terms of how much that can impact on prevention of heart disease and diabetes?
We hope it adds another element. So we hope we can identify people who may be at high genetic risk and implement some preventative strategies, lifestyle and behaviour. And if we in this study, we are sending people who are in that intermediate risk group off to go and have a CT scan to see whether there's any calcium buildup in their coronary arteries that supply blood to the heart. If there's evidence of some calcium buildup there, that would warrant going on some cholesterol lowering medication, some statin medication to halt the disease in its tracks. Mm-hmm. So if we did find, so the study's trying to see whether genetics can give us some more evidence as to who should go on and have that and more advanced testing. So the CT testing isn't available to everyone as it stands now. It's costly. It's minimally invasive, so it involves the injection of some radioactive dye to have it, and you do go into the magnet. So not everyone, it's not available to everyone, and our healthcare system unfortunately wouldn't make it available because it's too expensive. So we're trying to find other ways to detect who should go on and have that scan, and we're using the genetic pathway. So if we find that there is evidence of if our pathway identifies people who should have that, then we can get people onto preventative treatment earlier.
So then if you get good results out of that and you can then demonstrate the data, does that then lead to potentially bringing the cost down for those of us in the community?
We would hope that it could be used to inform the pathway and that management. So getting into the precision medicine, who should go on to have it and who shouldn't, who may not need it and who does need it. With the prescribing of the medication also, we're running a trial within this really large study to see whether we can motivate people to take their medications with the information that they receive. So we're giving half the people the results of their genetic test and half the people the results of their calcium test. And we're looking to see whether showing someone a picture of their actual coronary artery that's got some calcium built up, whether that inspires them to take their medications more or change their diet or exercise a little bit more. Can we instigate some further change with providing people with some more information about them that's personal to them?
I think being able to see it would actually help for you to take action, because that's one of the challenges with even in fundraising around heart disease is the first symptoms can sometimes be the last symptoms. So it's not as visual. You can't see it as well as you can with some other diseases. And all those not-for-profits that are raising funds for research, every single one of them is crucial and really important. But one of our challenges at the Baker is being able to see it. And I think if people can see it, you're a better chance to get action taken on it.
There's some research that has been done that says that. The other interesting, the flip side of the coin in this study is we're also showing or communicating to people what their genetic risk is. So they've inherited that risk from their parents, which is quite personal as well.
Yeah, absolutely. Well, there's a question that's popped up here from Jeff about, are we approaching a point where people proactively get DNA sequence done to know what their genetics are?
I think it is available. In terms right now in Australia, at least, this is not part of routine sort of clinical care, going and having a genetic test done. We're not that advanced yet. There's still a little way to go for us to offer that.
We had a question come in from Christy Baldwin, which also came in from Marina before the actual webinar got underway, and it's about the connection between heart disease and diabetes. Is there a link?
There is. Diabetes can predispose to the development of cardiovascular disease. So the excess glucose that's swimming around in the blood can affect the blood vessels, especially the very little micro vessels, and that can lead to cardiovascular disease. They also share the same risk factors.
Yeah, there's a question here that's come from Heather. I don't know how we're in a position to actually be able to answer. It's more of a communication question and a bit about the psychology of way humans behave, and what is the risk of blaming individuals who still get heart disease despite all the action being taken so-called healthy lifestyle factors. And I put myself into this category, Melinda, as somebody who I know that there is potentially the risk in my family, given my mum's side of the family with both her brothers and her dad passing away in their mid-40s. And I'm taking all the healthy lifestyle steps that I possibly can. But I think I would take them anyway, because that's the way that I enjoy living. I like to go for a bike ride, quite obviously. I like to have hit a tennis, run around the football and netball with my kids and so on, and take the dog for a walk. So that's a challenging one on human behavior.
Yeah. And diet and lifestyle behavioral advice is what we would give to anyone, whether they're on taking a pill or not taking a pill.
Yeah.
So look, there are heart health checks that you can go to a GP and have an assessment done. Are they perfect? Probably not. There's nothing that is. There might be someone that is low risk that happens to have an event. There might be people categorized as high risk and they don't have an event. It's a probability. It is a likelihood, which is how these algorithms are developed. They're population based. What we're trying to do is improve that, trying to bring in some genetics and other new biomarkers and new tools that can enhance that prediction and those algorithms. So look, there are things we can do and things we can't do. There are modifiable risk factors, like you've said. Do our best to eat healthy, to be physically active, to not sit down too much during the day. There are other things you can't control. Age, sorry, we can't change our age. Males are higher risk than females. We can't easily change gender. There are some things that we can do and some things we can't do. Genetics is another thing that we cannot change, but high genetic score or a high genetic risk doesn't seal one's fate. Yeah. There are other things that we can do. You might have high genetic risk score, but also have other, have a poor lifestyle or a poor diet, where you can change the poor lifestyle and the poor diet to try and minimize. And it's about minimizing risk.
Yeah, there are always outliers to all the norms. There's always somebody can say, but this person I know lived they drank, they smoked, and they lived till they were 99 years of age. But there's always going to be an exception. Yeah. You're talking about detection a moment ago and the work that you're doing around the research, which for somebody to get that level of detection, they need to be involved in a study with you guys. Amia asked a question before the webinar got underway about research being done to produce a device that could help identify or predict heart failure, heart attack, etc., ahead of time.
Yeah. So I'll give two examples. As I've alluded to in talking about the research that we do, we aren't developing a device per se, but we are trying to develop algorithms and using mass data and population data to try and predict risk better. Professor at the Baker, Professor Karl-Heinz Peter is another very senior researcher that you might have seen in the news at the beginning of the year. And he has funding, and it's been successfully trialled in an animal model for developing a specialised catheter and some infrared technology around detecting the unstable plaque and the plaques that are more likely to rupture. So the rupturing is what causes
That's the problem.
To the heart attack or a stroke. So he has the Baker, led by Professor Karl-Heinz Peter, are developing these devices to try and find the culprit plaques before they actually cause trouble. And as an addition to that, he's also identified a diabetes drug that might be useful in preventing heart attacks as well.
What's the difference between a heart attack and a stroke?
So a heart attack is when one of the a plaque would rupture and a clot will travel. When it travels to the coronary artery, so the arteries that supply blood to the heart, that will cause a heart attack. And when it ruptures and a clot travels up the carotid arteries to the brain, that will cause a stroke. So it's the artery that it travels to.
Yeah. Anna sent in a question asking, how do you know somebody's actually having a heart attack? What are the signs that you look for, and what do you look for in yourself?
Look, the typical you'd see on the TV symptom would be the chest pain and the crushing pain in the chest. You can also feel the discomfort in the shoulders and the arms, and also around the jaw and the neck and the back area. Dizziness and lightheadedness is another one. Nausea are some others. Shortness of breath, and cold sweats, or someone might feel a bit clammy.
Okay.
And women typically report that jaw and that back. Women typically, there's some slight difference.
So there's slight different symptoms between men and women.
Yeah. That they might be shared, but women report them more.
Okay.
It might be men experiencing them, but don't report them. But typically, women sort of report that jaw and neck pain a little more, and that nausea and the indigestion a little bit. Some women just say, I just don't feel right. I just, and the back pain, and again, I can talk from my experiences, Matt. My stepmom took herself to the hospital and said, I just don't feel right. I've just got this back.
She was having a heart attack.
She had an ECG, went home, and then and she had a full-on event a week later. She survived 2 heart attacks, but she just said, I just don't feel right. And it was it was back in achy. And
so is your advice, if in doubt, get it checked out?
Yep, definitely. Yep.
Okay.
No harm. No harm in going.
No. Well, Alan wants to know, and this one, Alan, I'm with you. This is totally out of self-interest. What's the major cause of heart attack in males over 65? And what is it in males over 47? I'm asking for me as well.
Yeah. The causes are the same cause at the same age, whether it's age or gender, whatever it is, that it's the same causes. And as we just outlined, it's when the rupture happens and it travels up to an artery that supplies blood to the heart.
Chris has asked a similar question about what's the age range? What's the main age range for people to have heart disease?
Yeah, so I'm just going to have a look at a note here, because I did look at how coronary artery disease is ranked in terms of deaths in Australia. So this can happen as early as your 20s. And I'll recall something I heard a couple of days ago. A participant wanted to participate in our study, which begins, the eligibility criteria for us is at age 40, because that's when you start to see it occurring more. Not to say it doesn't happen earlier. This person was 38 years of age, not eligible to be screened by us, but could go to a doctor if they wanted to. And had a heart attack 2 weeks later.
Oh, wow. So
it can happen at a young age, but it's coronary artery disease, which is a heart attack, is ranked number 4 in people aged 25 to 45. It then goes to first place ranking and second place ranking. So if we align that to gold and silver placings, coronary artery disease.
This is not a competition where we want to win medals.
No, you don't want.
We want to finish last.
Yeah, you do not want to win this one, but it is ranked first or second from 45 years and above, all the way up.
All the way through.
Yep. So it is ranked number 1 from 45 to 65-year-olds, and again it's 75 to 85-year-olds. And if it's not 1, it's number 2, and stroke kicks in at number 3.
Right. Okay. So really right in the belly of the Baker Institute and the work that they do. You mentioned participating in the studies. Marita posted a question a couple of moments ago about who is eligible to participate in the Baker studies and what do they need to do to be able to participate?
Yep. Thank you for that question. There are lots and lots of studies that the Baker have available that range across the spectrum of cardiovascular disease and diabetes. We have a clinical trials webpage that I will get the web link for you. And there's a whole list of projects there. They all vary in terms of the eligibility criteria. Some might be in secondary prevention. So we also run another one for people who unfortunately have had a heart attack. So, yeah, so the link's just been put up there, which is great. There's studies for diabetes, there's studies for COVID, there's studies for heart failure, for elite athletes. There is a whole range of studies that go to that site and see what's available and look at the eligibility criteria. And if you're interested, there'll be contact details there to follow up.
Yeah, so if anybody doesn't have the chat section open, a link has just been posted where you can go to find out how you can be involved in one of those clinical trials, what trials there are available to participate in. I have participated in one, Melinda. It was the elite athlete one, and I felt like a complete fraud. I had everything that met the criteria except for the elite part. I was an okay national level cyclist, but in this chart, there was Olympic gold medalists, there were people that won world titles, and then there was me. There was a Northcote Club cycling champion. That was about it. But I really actually enjoyed participating. It was good.
Yeah, that's good. Good. And look, if you're not eligible to participate and you want to be assessed, then your GP, you will be able to have a heart health check with your GP and have bare minimum, know your numbers, know your blood pressure, know your cholesterol, and know your risk. If you don't know your risk, you can't do anything about it. And there's so many treatments available to help people with their risk.
Yeah, Jeff has asked a question. Are heart arrhythmia deaths also counted as heart attacks?
No, I don't think so.
Okay,
no.
That's a fascinating. Jennifer has sent in a question in relation to genetics, which is right up your driveway. I have genetic high cholesterol, but my liver reacts badly to cholesterol lowering medication, so I can't take any. I now have fatty liver disease and am overweight. I find it hard to lose weight. Are there any other ways I can lower my cholesterol?
Yeah, sometimes diet and lifestyle aren't enough, especially if you've got what's called familial hypercholesterolemia, which is a genetic predisposition to having high cholesterol. Statins are so first of all, diet and lifestyle is the first point of call to try that. Statins are the prescribed medication that are hugely effective. They've transformed cardiovascular disease. But some people can't tolerate it. It's very few, but there's lots on the market. If one doesn't agree with you or doesn't work, try another one. There are lots of alternatives within the statin market. If statins cannot be tolerated, there is a new drug that has just broadened for who it's eligible for, but it always was eligible for people with familial hypercholesterolemia if that's what you've got, this genetic heart disease. But it is a new drug called a PCSK9 inhibitor. I believe it's an injection, and that also is hugely effective. So Jennifer, it maybe go back to your doctor, let them know about this. It's called a PCSK9 inhibitor, and just chat about your options, talk about it with your doctor and be guided by your doctor about what might be available to you.
Yeah, I've got a good friend of mine who's a GP, and there was a really good piece on the ABC recently on the Conversation Hour about the roles of GPs, and they are probably one of the most underrated arms of the whole medical field, I think, because that's the first port of call.
They are. Yep, they are the first port of call, and especially with diabetes, a huge amount of the management of diabetes is done in primary care by your doctor.
Yeah, there was a good question that came through from Gladys, and it's in relation to the Baker Institute. Does it coordinate its efforts with the Heart Foundation? And this is something that I often get asked in my role as an ambassador for the Baker Institute.
So we don't coordinate efforts, in terms of the word coordinate. We don't coordinate our efforts with them because we're an independent, not-for-profit medical research institute. But we do receive funding from them, and they are also a key advocacy partner in what we do. So you can go to them, we can go to them with our research findings and ask for their help to disseminate that to the medical profession, also to ask them to come along if we want to talk to government to try and influence policy and change something there. And also just to disseminate those findings to the general public. and they also do have some consumers, and they also help, you know, for us to design a research trial, we can design it in a certain way that we may want, but we also want people that it's going to have an impact on to have an input into how that's designed. And that's quite a newer thing in research the last couple of years, that when we build a trial or design a trial, we really need input way back at the beginning as to how that is designed by the people that it's going to affect. So the Heart Foundation sort of helped to put us in touch with people as well.
So the actual research element is done independently, but all the other elements, you're both allies and trying to work together to get the better outcome. I guess a successful outcome would be for both those businesses to be out of business.
It would be, yeah, it would be, but there's a long way to go. Unfortunately, there's a lot of work to do.
Christina asked the question: will there ever be a cure to heart disease and/or diabetes?
Well, I hope so, and we're trying to find one. But as I said, there's a lot of work to be done.
Yeah,
that point.
Another just quick question coming in. I'm not sure whether you're in a position to answer this, but it's from Silas Warren. I have high cholesterol reading, but 0 calcium score. What are the risk factors?
So your risk factor, so on the basis of your cholesterol, the doctor would perhaps look at your combined risk. So put your numbers, look at your age, your blood pressure, whether you've got diabetes, whether you're a smoker or not is a key one. Put them in and do a heart health check and be guided by that result as to whether you should be prescribed a medication or not. If your cholesterol is too high, then that could be treated and medicated. If they haven't already tried, if you haven't tried diet and lifestyle, that could be medicated without going to have a CT scan. The CT scan is really only recommended for people in that intermediate group. So low's low, it's great. You think your risk is low, keep doing what you're doing, that's good. High is high. We need to address what is causing that risk to be so high. Intermediate is where we think we can offer some more help and guidance to doctors. So the intermediate group, if there's a family history, for example, or other things that might we might need some more help and guidance, your GP can send you off to go and have a CT scan then. So the CT scan is really used to risk stratify and to group people a little bit better, but it's not the only diagnostic tool to help.
Yeah. There's been a couple of comments that have been posted in the chat that I don't think we're in a position to be able to answer here on the webinar itself. One of them from Irene was in relation to a recommendation for somebody in Sydney. The Baker will endeavour to get back to each of you that have posted those questions that we haven't been able to answer. It's been a pleasure to have a chat with you, Melinda, about the work that you're doing. And I mean, it really is a dream for everybody for the Baker to be out of business, but it's been here for 95 years and it continues to work really hard to help people and reduce the amount of deaths as a result of heart attacks and diabetes.
Yes. Yeah, we're coming up to our 100th birthday, a couple of years, but yeah, I love the work that we do. I hope we're making a change and making a difference, and we will continue to do so.
Well, thank you, everybody.